Well, thank you, everybody, for coming. We appreciate it. I'm Paul Glastris. I'm editor-in-chief of the Washington Monthly and a fellow here at the New America Foundation. We're here today to chat about the second edition of Phil Longman's great book, Best Care Anywhere. Phil Longman is an old friend and frequent contributor to the Washington Monthly, now the Bernard Schwartz Fellow at the Washington Monthly and a longtime fellow here at New America. I guess it was about 6 years ago, Phil, that I gave Phil a call trolling for stories, and we tried a couple of ideas. It didn't quite gel. Next day, Phil calls me back and says, I do have one story for you. He said, how about a story about how the best quality, most cost-efficient healthcare in America is being delivered by a giant government bureaucracy, the VA. And I thought, that's an interesting story. And I guess I was an easy mark because we write about government, but also I had done a little reporting some years earlier for the New Republic about the reinventing government efforts of the Clinton administration and visited a VA facility in Milwaukee and saw from my own eyes that they were actually doing some interesting things. So I said, sure, Phil, give it a go. So he sends me the draft, and it kind of blew my mind. And we published it, and I think it made some waves, but among a few. But I think it was so hard for people to get their heads around the idea that it was a little slow taking off. We tried two more stories that Phil did on the basic issue. One on why we could take the VA model and create a civilian version for all those who are unemployed, and yet another piece about the $17 billion program that the Obama administration passed with the stimulus package for healthcare IT. And still this idea continues to bubble up out there. And so much so that Polypoint Press decided to reissue the book that came from the magazine articles in the Washington Monthly, Best Care Anywhere, which has gotten, as I said, quite a following in the policy world. I think both Hillary Clinton in her campaign and Barack Obama in his brought Phil in for some guidance on how the VA model might fit into healthcare. More and more, and Phil didn't make this up out of whole cloth. This was he was basing his reporting on studies that had been done in the finest peer-reviewed journals in the country. But as I said, it's so hard to get your head around the idea that the best quality, lowest cost healthcare in America is being delivered by the VA and not some of the fanciest academic health centers in the country, that there's still a kind of general unwillingness to grapple with this. So I think both Phil and I were a little disappointed when the healthcare bill ultimately passed, that the notions that were implicit in and explicit in Phil's writings about taking the VA model and implementing it in the civilian sector weren't really parts of ultimately of the discussion or in the bill in any obvious way. In a sense, we dealt with insurance in access in this healthcare legislation, not delivery reform. But the more we've kind of looked into it, Phil's looked into it, the more I think that you are going to see in subsequent years, and that this legislation and some of the other things that have passed under this administration are creating the conditions whereby the civilian VA idea, the idea of recreating an integrated healthcare system using the IT revolution that the VA pioneered, has a potential to be created in the laboratories of democracy out there. And there are some very, very interesting, already some very, very interesting early experiments that we're keeping an eye on. So this is a story that really only the first few chapters have been written, and I think you're going to hear a lot more in subsequent years as we turn to delivery reform about the VA model. So with that introduction, let me begin by asking Phil, on that day that you offered that story idea, the Washington Monthly, I don't think, was your first choice of the place to tell that story for us.
Okay. Well, thank you, Paul, and thank you all for coming. The origins of this book actually begin one day in about 2004 when the editors of Fortune magazine summoned me to New York for what turned out to be a sumptuous lunch and a very difficult assignment. In their glass towers up there on 6th Avenue, they had come up with this story idea, and it was rather clever. They said, well, you know, we would like you to go out and find whoever it might be is the Jack Welch of healthcare. Jack Welch being at the time, of course, the storied CEO of General Electric, who'd been on Fortune's cover basically every other issue throughout the 1990s. So I listened to that, and I thought that would be a good assignment. Part of it was just intellectual. At the time, it was already clear that the American healthcare system was out of control and its cost, but part of it was personal too, because I had lost my wife, Robin, a few years before to breast cancer, and what I had seen of the American healthcare system, or at least one little prestigious corner of it, during the 18 months between her diagnosis and demise, had caused me to really be quite radicalized about healthcare delivery. Robin was treated at the Lombardi Cancer Center. It's over here. It's part of the Georgetown University Hospital System. We were very grateful at the time that we had access to this world-class facility. I remember particularly Robin saying to me how grateful she was that she had not taken my advice to try and save money by enrolling in HMO. And we were further encouraged every time we went into this facility to see this giant blow-up of U.S. News and World Report cover their annual hospital rankings, which put Lombardi at the top of cancer treatment, not the very top, but among the top cancer treatment facilities. And since I worked for U.S. News at the time and had respect for the people that did those rankings, that was quite reassuring. But as time went by, I began to be more and more bothered by the little things, you know, like why was it that every time we came in, her paper files seemed to be scattered all over the facility. The X-ray was over here, the lab results were over there. In one particularly difficult moment, we started a consultation with her team of oncologists in an examining room. And the conversation started off on what we thought was a very promising note. They began talking about Robin's prospects for reconstructive surgery. She was at that time undergoing chemotherapy. And obviously, if you're going to be talking about reconstructive surgery for her lumpectomy, then that would imply that you had a great deal of confidence that the cancer was in remission. So we talked about that for maybe 20 minutes, and eventually I began to notice this one resident sort of tentatively raise her hand and say, guys, did anybody remember to look at that liver scan that we did last week? All kind of looked at each other and then looked at us and said, be right back. And so about 45 minutes later, this grim-faced oncologist returned with the news that the cancer had spread to her liver, and such was his clinical prowess he was able to predict that she would die within 17 days, and she did indeed die exactly within 17 days. So now I never blamed her doctors for her death, but it became very clear to me that they were operating under a system that was highly disorganized and prone to medical error. It's sort of as if you showed up at an airline gate and the person there told you, well, we're not quite sure where the plane is that your loved one is on, and we can't really say whether it passed its last inspection, and by the way, no, we don't have a passenger manifest. So, I set off on this assignment with a great deal of passion, and one of the first things I did was to go up and to Cambridge to visit Donald Berwick, who some of you might know has just been appointed by the Obama administration to head up the Centers for Medicare and Medicaid Services. I think it's a wonderful appointment. At the time, he was already kind of the guru of the then still nascent healthcare quality and safety movement in the United States. And so I went up and essentially sat on his knee for a whole day, saying, you know what, they gave me this assignment. Who is the Jack Welch of healthcare? And in so many words, and I heard this again and again from other people who were similarly engaged in the quest for healthcare quality, they kept suggesting to me, well, actually, this government bureaucrat, it's this guy named Ken Kaiser, who kind of in the late 1990s, mid to late 1990s, came in under the radar as a Clinton appointee to the Veterans Health Administration and took that organization by the throat and turned it around and turned it into best care anywhere. And I thought to myself, come on, give me a break. I had actually written a book about 10 years before in which I had proposed that in the context of general entitlement reform that the veterans just be given vouchers because the VA was so obviously broken and busted. And this was an opinion that was shared across the ideological spectrum at the time. So I was not inclined to believe this at all. But I began looking at this peer-reviewed literature that Paul referred to and that Berwick and others pointed me to, and I read all this stuff about, well, okay, on all these different metrics of quality, rates of medical error, patient satisfaction, adherence to protocols of evidence-based care, cost per patient. Kept doing all these studies of all these different healthcare systems, and time again, here's the VA on top. So that just basically started smoke coming out of my ears. And I went back to Fortune magazine. I said, well, I don't know if you really want me to continue reporting this story because I think I know who the Jack Welch of healthcare is, and he's this government bureaucrat. And they said, no, just forget it. Here's a $2,000 kill fee. It's been nice doing business with you. Check in later. Then I remember there's this guy, Paul Glaster, that's receptive to crazy ideas, and as Paul described,
especially when somebody else pays him $2,000, it's going to come out of our pocket. Yeah.
So, at Paul's insistence, I started not just reading and talking to experts, but actually going out to various VA hospitals. And I'd spent a lot of time in hospitals in my late wife's illness and other things. And when I got to the VA hospital, I noticed things that were different just superficially right away. One is a certain ritual that you could already in those days see and still see in VA hospitals, won't see virtually anywhere else even today. Comes time for a nurse to administer a med to a patient. Watch that she has a wand in her hand. Waves that wand on her wrist where there's a barcode on a bracelet. And she waves that wand on the patient's wrist where there's also a barcode. And she waves the wand on the med where there's also a barcode. If it's the wrong patient, the wrong med, the wrong dose, the wrong time, alarm goes off, it prevents a medical error. Might sound like a small thing, but the Institute of Medicine recently estimated the average American hospital experiences one dispensing error per day they're in the hospital. About 78,000 people a year to complications from medical errors involving prescription drugs. So this was a big thing. Another thing I noticed was as you walk down the wards, you'll see doctors with these little carts that they're pushing in front of them, and on top of the cart is this laptop computer. Now, by now, it's not that unusual to go to a doctor and have him whip out a laptop computer, but this was different. And bear in mind, this was 5 or 6 years ago. This laptop computer, when you opened it up, it actually was connected to data, specifically the patient's complete medical record, including all scans, lab results, and such, going back to 1986. And I began talking to various VA doctors, and I said, well, how does this actually affect your practice of medicine? And they said, well, the first thing it means is we see a lot more patients because we're not running around all the time trying to find where is that liver scan, where is it, you know. But it also turned out that it was an amazing tool to diagnosis. The VA, even by that point, had wired itself up to the point where a patient at home was equipped with telemedicine devices, so they would step on a scale every morning, for example, and their weight would be recorded in real time into their electronic medical record. Same thing with blood pressure, glucose readings, that kind of thing. I won't get into the details of it, but many times a very difficult diagnosis can be made when you find that, for example, there's a certain pattern to a person's weight or a certain pattern to their blood pressure. So all that made me quite enthusiastic to figure out what this was all about.
And at some point you discovered the origins of this computer system.
Yes.
And in your book you talk about the hard hats.
Yeah.
Tell us about that.
Well, since this proposition that I'm laying out here, that the VA offers best care anywhere, it's helpful to actually get down in the weeds a little bit and say, how could this be true? After all, it's this gigantic bureaucracy. It's highly unionized.
How big is the VA?
I think I got 280,000 employees, 5 public service unions representing. This should not work. It's micromanaged by Congress, micromanaged by political appointees, including some pretty hard dudes during the Bush administration, and yet the thing takes a licking and it still keeps on ticking. So what's that all about? So one of the first things I discovered is kind of an inspiring story. I just love this story. It starts in the late 70s, and the VA at that time is totally dysfunctional. This is the worst of the Vietnam era, right? You have Vietnam vets surrounding Max Cleland, who was Carter's VA secretary, quadriplegic, in a wheelchair, wouldn't give him what they wanted on Agent Orange, and they were screaming at him, what did you lose your balls in Vietnam too? That was kind of the atmosphere and how vets at that time felt about the VA. And from the point of view of the frontline personnel, they were facing just impossible working conditions. They were underfunded in these terrible hospitals. As some of you might have seen as depicted movies like The 4th of July. And so they, some of them, just decided that they had to do something to just improve their own working conditions. And you'll recall that this was the era when, for the first time, if you had a Phillips head screwdriver and a few gears in your head, you could go down to Radio Shack and you could buy for maybe $5,000 this kit that you could put together to make this thing we today call a personal computer. It had 50-character screen and 2 floppies, and you had to build it yourself with a soldering iron and stuff. But anyway, here and there around the VA, various folks started saying to themselves, well, you know what? If the VA can't keep my paper records for my patients, what if I just take one of these Radio Shack kits, or Tandies, and put it together? And
this was at a time when the VA, but every other organization, was using, centralized mainframe computers for everything.
Like everybody else, to get the pensions out, to do, and various attempts had been made to use the high priests that ran the mainframes to do some kind of health IT. And it turns out that their product cycle was literally 6-7 years, right? You put in an idea, and 6-7 years back, the central office would come back with something that didn't work. So these guys started doing that, and before long, central office got wind that there was these VA doctors who were on company time using personal computers. And the high priests that ran the mainframes, they was like, nobody here does computing. That's our department. And so it got uglier and uglier. There were congressional investigations about all these personal computers that were being ordered. There was Office of Management and Budget coming down on them. People were fired. Even got tougher than that. There's a wonderful fellow named Ken Dickey, who at the time was running a geriatric ward at the Washington Medical Center over here on Irving Street off North Capitol. And he was completely overwhelmed. And so he was among these so-called hard hats, as they came to be known, who had this, in his case, a DEC mini computer. And he was in the basement of that hospital a lot of the time, trying to create actually creating what was, in effect, the first electronic medical record system. And that was so threatening to somebody that one day somebody took all the paper files that were stored down there in the basement and covered over this DEC mini computer and poured some kind of flammable material on it, set it afire. They had to evacuate the whole hospital. He was reprimanded for behavior. That ratcheted up another level, so that now even personal computers that the VA itself owned were put in warehouses where the doctors couldn't get to them. And so there developed this kind of subculture. Some people called it the Underground Railroad. Other people called it the hard hats. They had little business cards with a picture of an underground railroad, which they would give to each other so that they could kind of know that they were part of this secret society. They used to do what they call commit portability. In those days, there was no way to get a program that that Ken Dickey, for instance, might have crafted for electronic medical records in Washington over to, say, the VA hospital in San Diego. So they would download it onto these cake trays of silicon and put that in a trench coat, get on an airplane, ride across the country, guys show the secret cards. It's like, okay, let's swap. Right. It got more and more subversive. Nobody was allowed to order a PC anymore, so they would order what were, some of you might remember, the old Wang word processors. The secretaries used to use in the late 60s. These were dedicated machines. They only could be used for word processing. They had no floppy drive on them. They would order these things from central office because they would just say, well, with all the paperwork you're giving us, we got to have one of these Wangs, right? And then when the thing came, they'd unpack it and get in there and rewire it so that there was a floppy drive that they could download to, or hook it up to a 300 baud modem so that they could, or an analog telephone wire, shoot these various programs across the country. Well, that went on, and amazingly, it just got more and more buy-in from these frontline employees of the VA. These programs were written by doctors, for doctors, and guess what? They were pretty good. And eventually, there was a full-fledged rebellion going on in the VA with these guys. And a fellow named Chuck Hagel, who at that time was not yet a senator, he was just new to Washington. His first job here was as VA Undersecretary for Information Technology. And he heard about all this, and he looked at these high priests up at Hines, Illinois, that had these big mainframes and how dysfunctional they were, and he said, well, you know what? Let's just go with the hard hats. So that actually was empowered. So that was a kind of revolution from below that bubbled up. And it was met a short time later from a revolution from above in the form of Ken Kaiser, who was amazing individual.
He was a public health guy. He wasn't.
Yeah, he was at age,
he had no
at age
veteran.
30. He was running the California public health system. Her department was very active in California's anti-smoking initiatives, their AIDS initiatives. This was still in the 80s. Was a rising star Republican. Now remember that in this era, the Clintons had other ideas for American healthcare. They were going to have this gigantic system of alliances, and in their worldview, the VA was going to just get folded into this overarching healthcare reform. So they didn't pay much attention to whoever might be the chief doc of the VA, and so they appointed this guy without paying much attention to who they were appointing, or even that the guy was a Republican. But Ken had this background in public health, and through that experience and training, had this kind of habit of looking at healthcare as a system, looking at not how it dealt with individual patients with individual conditions, but rather how, as a system, it worked to improve population health as a whole. And he was particularly attracted to the VA because the VA, almost uniquely among healthcare providers, certainly large ones, had nearly a lifelong relationship with its patients, which meant that it could have an actual business case for investing in prevention, wellness, effective disease management, because when, for example, a patient presented at the VA with prediabetes, if the VA would spend the money to educate that patient about the disease and how to manage it, and would themselves create a team that would advise the patient on all the different aspects of being a diabetic, what that meant was down the road, the VA would save all kinds of money by that patient not being a candidate for amputation, dialysis, blindness, all the other complications. This is something that Ken well knew from his own experience did not apply elsewhere in healthcare. That if you tried to make a business case for let's have a smoking cessation program or let's do what everybody says is best practices in diabetic care, it turned out that you would lose money on it because whatever good you did to the patient, those benefits would not show up until many years in the future, by which time that patient would have long since gone on to some other healthcare insurer. The VA just, by its nature, didn't have to worry about that, and it also meant
because I guess the point is a veteran comes in for VA care maybe after serving in a war and in his 20s gets his first care and is continuing to get it until he's a very old person.
Yeah, potentially long-term nursing home care is an entitlement under our VA. So, yeah, they had to take the real long view.
And so what did Kaiser do when he engaged with the hard hats, and what did he do with this?
Well, the first thing was to realize and exploit the potential of this health IT, that they had digitalized huge amounts of information about how things were actually going. So in the early sort of primitive days, they tried to develop metrics that were mostly involved inputs, not outputs. So curious, like what percentage of our senior vets are getting their flu shots, right? And so a couple keystrokes, it scans all this gigantic patient records. And I thought, oh, it's like only 50% of our guys get flu shots. Well, why is that? And how come it is over here in London, 80% get them, and down here in Louisiana, only 20% get them? So you instantly begin to see that as a management tool. And, we'll go over here in Louisville, the mortality rate for the surgeon team is 5 times what it is for the system as a whole. Let's go down to Louisville and see what's happening there. Is it just have coincidence they had a bunch of hard cases, or is there something else going on? So this becomes a very effective management tool. Next thing he did was try and decentralize the VA as much as possible. When he first got there, he said on his first day, he found on his desk this requisition reform. Somebody wanted in Utah to buy $11.82 cable modem. And that went all the way up to the undersecretary, right? He said, you know what? Since with this electronic medical or IT, I kind of keep track pretty well, of what people are doing and what kind of results are going to. I don't need to have that kind of system anymore. I can trust you to spend $11.82 of the taxpayers' money.
All by your lonesome.
Yeah, right. But by the way, at the end of this next quarter, you're going to stand in front of me and tell me, what actual outcomes you got with your patients. So he did that. He broke it up administratively into I guess 22 different regions that the VA runs. So that was good. The next thing he did was he wanted to change the focus of the VA from acute care, that is hospital treatment for conditions like heart attacks, to one that still did that, but much more emphasis on primary care. So a big radical thing he did was make sure that every vet in the system had a primary care doctor, right? And he closed a lot of big old hospitals and replaced them with clinics in the neighborhoods where vets could get to them easier and where they could get services like smoking cessation, mental illness, other substance abuse, and just basic primary care. And again, that paid long-term benefits in cost savings to the VA. Now, initially, the veterans groups, the first thing they noticed is, hey, you're closing VA hospitals. That's wrong, right? And as it turned out, between Disabled Vets of America and the American Legion, by 1999, Ken Kaiser was run on a rail out of town. He got crosswise with John Kerry because the VA at that time had, and still does, has 5 VA hospitals in Boston. They might need 1, given the volume of care. Kaiser had tried to rationalize that. The unions and other people in Boston had gotten to Kerry, put a hold on his nomination, so Kaiser was gone. But the reforms that he instituted lived on and kind of became part of the DNA between the hard hat culture and the charisma that Kaiser had provided. It turned that organization around. It turned its culture around to the point that 8 years later, the American Legion gave Ken Kaiser a Lifetime Achievement Award.
And an apology, I hope.
An apology. Well, I don't know about an apology. And, the VA now has the highest patient satisfaction of any healthcare provider in the United States. I had the wonderful experience this summer of being invited to address the American Legion's National Convention in Louisville. It started off with a 6-hour parade down Main Street. A lot of these guys don't move too fast anymore. So I found myself up on a podium looking out at this audience. It's all bedecked with the traditional symbols of American patriotism, it's small town, red America. And the theme of my remarks was socialized medicine. And it's like, you guys know what it is. You guys know how good it is. Go out and tell your neighbors, and let's turn this thing around. And got a standing ovation from the American Legion. So that's sort of takes us up to where it happened. Over time, more and more people in the sort of policy world began to take note. You can't help it, but if the New England Journal of Medicine, the Annals of Internal Medicine, all these other health affairs and other people are constantly publishing these articles about how the VA has got outliers. And there's a lot of denial. There's a lot of saying, well, VA is a special case. It's a closed system. There's got to be something about the military culture of the VA that, it's some reason why it can't be replicated.
And in fact, they have kind of sicker patients than on average, right?
On average, yeah. The average vet is older than the Americans in general, more inclined to substance abuse, mental illness. But 1 out of 6 of them have diabetes. This is a very difficult population. And yet, although it's not possible to get really precise cost comparisons because many vets get not all their health care at the VA, they get elsewhere too, but it looks like a good ballpark number is that for every vet we might get to off of Medicare and into the VA system, that vet would get higher quality care. The statistics tell us he'd be more inclined to be satisfied with that care, and the taxpayer would save probably about a third of the cost of what Medicare pays. So it's a win-win situation, which is what got me to thinking about how can we apply these lessons more broadly. So maybe that's time to talk about that.
Well, let's do that. So I have to say that not only was I persuaded by Phil's first piece for me, but at the time my father, who since passed away, had Parkinson's, and I'd arranged for him to have, I found the best neurologist in St. Louis, my hometown, at Washington University, great guy, and I'm sure he got tremendous care from the fellow, but I remember taking him with my mom to this guy's office, and he'd come in with this big fat folder full of medical records, which he had written himself. Then he'd come in, he'd sit down, and he'd open the medical records and said, "Bill, what did we do for you last time?" And he'd started flipping through them, and he was an older gentleman himself, and did we ever prescribe that drug? And my mom, who is unbelievably organized, would pull out her file, and she said, "Well, his internist already prescribed." "Oh, okay." So and then ultimately we were able to get him VA care toward the end of his life, and we'd go into the VA hospital in South St. Louis, and there was a wonderful young doctor there, and we went into her office, no paper at all, and she just tick, tick, tick on the computer, and there pops up all his records. And it was just stunning to see. All he got was his meds there because it was cheaper. But it really is true. And you talk to almost anybody who has that experience. I mean, there are some bad VA facilities out there, that's for sure. But it's true. So the question is now, we've just gone through a year and a half plus national conversation, and finally passed a historic health care bill. The bill ultimately did not do anything for the delivery side of health care.
That's right.
It was essentially an expansion of health care access to insurance, I think is a fair estimate. But in that bill, and I'm sure you all have read about this, is hundreds of little provisions and pots of money and regulations and things that empower different bureaucrats in Washington and elsewhere to do things. And my sense from talking to you earlier yesterday is, having looked at some of that, well, let me tell you about this, the second article that we published a couple of years ago that sort of took the VA model and said, how could you recreate this in civilian life? We've all heard of certain care organizations like Kaiser, like Intermountain, that have been written about, that have some form of integrated health care. Some have applied electronic health records more than others, have higher quality, but they're few and far between. And they don't have what was essential to the VA, which is an alignment between the interests of the organization and the interests of the patient, that is lifetime care, right? So that if I invest in smoking cessation as an healthcare organization, I have some assurance that I'm going to not be putting money in my competitor's pocket when that patient then goes on to the next healthcare organization. So one of the assignments that I later gave Phil was design out of your mind what a civilian version of the VA would look like. And so tell us about that vision?
Well, that basically starts with the observation that basically in every community in America today, we have what I like to call a St. Elsewhere. Folks remember that program from the 1980s? It was about a big public hospital in Boston and the travails of the staff and their various affairs and things. But anyway, basically everywhere in the country there's some equivalent. There's some big public hospital that's kind of the safety net. In New York City, that's Bellevue, right? In Denver, that's Denver General. And these places are hard hit, right? They've got a population that's mostly uninsured. They're usually in declining neighborhoods. And they're in danger of being closed and are being closed all over the place. New York State, through a process that's sort of akin to a military base closing process, has taken the decision to close 20% of all hospitals in New York State in the next few years. And that means that if you live in the South Bronx, for example, you soon have to take a bus on a winter's night an hour and a half to get to Columbia Presbyterian or wherever the closest thing is. Now, there's a lot wrong with these St. Elsewheres. They're focused on acute care. But there's a good case for providing these populations with quality health care. So,
I mean, isn't it the case that if you're uninsured, though you get maybe half as much health care, the health care you get is better?
Well, yeah, that's an amazing factoid. So if you add up all the medical errors and unnecessary treatment and such, right, it turns out contact with the U.S. healthcare system is the third leading cause of death in the United States, right? It's just behind all heart disease and all cancer, right? 250,000 Americans killed every year in the hands of the American healthcare system, all right? So how do you insure yourself against getting killed by this very dangerous thing? Well, one good way is to not have any health insurance. And Rand came out with a study a couple of years ago that demonstrated this, that when it came to acute care, the headline was, a lot of you probably saw it in the papers, that if you go to a healthcare provider, your chances of getting appropriate care are basically about 50%. Random, right? Overtreatment, undertreatment, mistreatment, whatever. Between all that, random, right? But if according to the study, if you had no insurance, your chances were a little better than random of getting appropriate care. I thought, when I first saw that tab, I thought somebody forgot to carry the one there. That cannot be, right? But actually, it makes sense when you think about it. What is acute care? That somebody presents at the emergency room. They're having a heart attack, right? They get wheeled in, code red, right? They find out the guy doesn't have insurance. What do? Well, they got to patch him up, right? That's their obligation. But they also want to get him out the door as fast as possible, which means no unnecessary testing, no heroic, unproven surgery. So by the time when Rand goes in after the facts and looks at these various patient records, it's like, yeah, having no insurance is good insurance against the third leading cause of death in the United States. All right. So there's that. And then there is also, out of the Dartmouth Medical School and all the work that they've been doing on the geography of medicine, the crazy quilt pattern of practice patterns. It turns out, at the end of the day, the higher you are listed in the U.S. News rankings of prestigious hospital providers, the more likely you are to have low quality. And it's the hospitals you never heard of, the suburban whatevers, and even the St. Elsewheres, that actually, at the end of the day, are providing better health care. And that's because mostly they don't have so many specialists over-treating folks, and they've got a culture of medicine that's basically basic blocking and tackling rather than heroic stuff. So so even as broken as it is, this system of St. Elsewhere has its virtues. But what if we took this basic proposition, which is to say to some St. Elsewhere, look, if you will wire yourself up with the VA's health IT system, and by the way, it's free, right? Because it was created by public employees on public time. There's no patent on it.
And it's open source.
It's open source. So it's free to you. We'll give you some technical assistance in installing it. It's not a small thing to do this. It's not a small thing to change the culture of medicine so that you can take advantage of it. You do that. You accept you follow the VA's protocols of care. The VA, because it has these information technology systems, was able to see quite easily that, for instance, most back surgery is not as effective as physical therapy for back pain. So it does very little back surgery. Because of its health IT system, it was able to glom onto the fact faster than just about anybody that Vioxx was a dangerous drug. Vioxx killed more Americans than died in the Vietnam War after getting FDA approval and being sold to us over television for 5 years. Eventually, VA, through its information systems, noticed that they're having clusters of heart attacks. And with a few more mouse strokes, you said, what in the world do these people have in common? Why are these clusters? Can't find anything in common these guys have, except the computer will tell you very quickly. One thing they have all in common is they're taking Vioxx. So VA shut that down long before anybody else did. So if you will adopt not only the health IT systems, but the protocols of care that are informed by those IT systems, the evidence-based medicine, we will guarantee you a certain population to take care of. And those would be people who are newly mandated to buy health insurance. The default option would be that if you're such a person, you go into the civilian VA facility, unless you choose otherwise, right? And we get a. Now, it's funny because today, or over the last few years, healthcare policy wonk community has been very busy reinventing the VA without admitting what they're doing, or perhaps not knowing what they're doing. The new buzzwords are everybody should have a medical home. We should have accountable healthcare organizations, right? Well, VA was an accountable healthcare organizations before accountable health organizations were cool, right? So anyway, to bring this up to the current moment, there are, as Paul alluded to, in this 2,800-page legislation we just passed, in terms of pure page count, about 4/5 of it doesn't involve insurance coverage. Most of the actual paperweight of that thing is describing various demonstration projects and things that you could be eligible for under this legislation. And the language that is used there is like, well, if you're a state and you would like to experiment with creating an accountable healthcare organization, meaning that you would have a healthcare provider where the doctors were on salary, where there was meaningful use of electronic medical records, where there was integration so that patients under the same system would have access to social workers and people that advise them on diet and lifestyle and all that stuff. There's language in this legislation that says there's a pot of $10 billion out there to anybody who wants to play around with that kind of idea, right? There's also another new $10 billion in there to any state or nonprofit organization that would like to set up a series of public health clinics and link them up. And again, VA did this in the early 90s, right? So on the application, be sure not to say, I want to start a civilian VA. Just say, I want to start an accountable healthcare organization, but then take your lead from whatever the VA has done. And
there's also about $19 billion from the stimulus money
Yeah.
that is for healthcare IT. And
Yes.
You can either go spend that money on on some consultants to help customize VA type or VA specific programs, or you can go buy a proprietary system.
Right. This is another large subject, but yes, under the stimulus bill, there was $17 billion put aside. Basically, it comes down to each doctor in America can receive $18,000 to install health IT. We're bribing them to do the right thing because their business model doesn't actually compel them to do the right thing, because we don't pay for quality, we pay for procedure. So we try to overcome that. Well, as I said, the VA code, written by doctors for doctors, starting on these little Tandy machines, is out there. It has itself migrated outside of the VA as a code in this open source world that it lives in. So, for example, Jordan is right now in the process of wiring up all of its hospitals with VA healthcare. There's a nation industry of people who basically are in the business of allowing you to, as a healthcare provider, or enabling you as a healthcare provider to take that free Vista software, this is called, and put it in your hospital. Midlands Memorial Hospital in Texas just completed a very successful installation of VA software using the services of a company called MedSphere. It came in with tremendous buy-in from the staff. Not like Cedars-Sinai in Los Angeles, where they wound up ripping out the new system because the doctors couldn't stand all of its bugs, and because the proprietary company that put it in wouldn't cooperate in fixing it and stuff like this. It's a very successful installation. It cost about a third of what it would have cost proprietary stuff. So this is within the reach of anybody who wants to do it. There's plenty of people will take your call if you want to wire yourself up, either as a hospital or even as a sole practitioner.
So what entities? Is it states? Is it cities? Is it hospital administrators? Who is going to have the capacity to react to and experiment with these pots of money that are being made available by the federal government? And what might it look
any
like?
state is entitled to this money. Any nonprofit that just wants to say, we would like to try a demonstration project. Now, it's telling that even with this $17 billion in the water, there's been basically no take-up from private healthcare providers on this health IT, because $18,000 to wire yourself up, that doesn't nearly compensate them for all the hassle of doing it. And since they're not paid for quality, the quality benefits of that are immaterial, no business case. So who is wiring themselves up with Vista and other open source software? The Indian Healthcare Service, right? Various prisons, the public healthcare systems of other countries like Norway and Jordan and Egypt, have all taken this. And why does it make sense for them to do that where it doesn't make sense for private providers to do that? Because they, like the VA, have these guys for life, or at least a long time, and quality actually pays for them. Whereas the fee-for-service, for-profit medicine, there is no case whatsoever for health IT.
Is there any example out there now that you look at and say that could be a kind of exemplar of how you could create something like this civilian VA that you're talking about?
Well, we see the public hospitals of West Virginia are well into the process of wiring themselves up with Vista, the VA open source code. Midlands Memorial is a nonprofit hospital. Therefore, they're not as sensitive to the rate of return. But it's fascinating. If you pick up the current issue of Health Affairs, which is the sort of leading journal of health policy. And there's two. The whole issue is dedicated to health IT, and there's two articles in there that are wonderful companion pieces. One is about this New Start system in South Jersey called Atlantic Care, and they figured, well, since we're new, we'll just start off right, and so that means we want total information technology in there, and so they went to a private proprietary firm called eClinical Works, paid millions and millions of dollars to get this system in, and as you can read in Health Affairs this month, it was a total disaster, right? Buggy, doesn't really apply to their business and way of doing things. No ability to change it, right?
Like Microsoft.
Kind of like Microsoft. All kinds of data trapped in black boxes that none of your people have any way of getting it out, unless this guy who now has captured you, the proprietary software vendor, you make a case to him why he should bestir himself to do that. Also, completely lost is the opportunity to build it into the culture and practice of medicine, because it's not written by doctors for doctors. There's no ability to modify it to your own use. So we have this whole terrible story about, what a disaster it was. And this is one of a long series of stories, I wrote about early in the Washington Monthly about Children's Hospital in Cleveland had a very similar situation. Mount Sinai and Los Angeles. This is basically the pattern when no good deed goes unpunished in American healthcare, when people have tried these proprietary systems. In the same issue of Health Affairs, there's a companion piece talking about the VA's experience. Well, and it's, all good, right? It's not written by VA doctors, it's written by some lead authors from Partners Healthcare, and they're talking about, well, the VA got this tremendous return on its investment because it was written by these hard hats, basically on company time. The actual cost per patient of the system is only about $90, and yet it's seamless and it's integrated and has been for 10 years. It's just this wonderful feel-good piece about the VA system. So I think in some ways it's good that there's so little take-up on the stimulus bill, because the thing I was worried about a year ago is that in short order, average American would go into their doctor, wait for 2 hours for an 8-minute consultation, only to be told by the doctor, well, it's this goddamn government-mandated software is the reason you had to wait 2 hours. It doesn't work. And that'd be another reason why people say, get the government out of healthcare. But sort of the silver lining is there hasn't been a huge take-up. So we still have time to do this right. There's a wonderful little pilot project just starting up now in San Diego between the VA Medical Center there and Kaiser. Kaiser's the closest thing there is to a civilian VA right now. Great big staff model, HMO, fully implemented health IT. But there's one big problem. A lot of vets in San Diego get their care both at the VA and at Kaiser. And these two institutions can't talk to each other. So, in effect, you got real vets carrying around like your dad or your mom, these gigantic piles of paper between these two facilities. And they have now figured out a way to take yet another open source piece of code that will allow Kaiser's proprietary system to talk to the VA's open source system, so that if all goes well, there'll be seamless integration between these two things. And that is technically possible. And so we have the opportunity to not only turn around a lot of individual St. Elsewheres, but ultimately to wire them all together into a kind of virtual delivery system, such that wherever you are in the country, when you get sick, you can go to the local, let's call it Vista Life Network hospital, and they will have, at a keystroke, all your electronic medical records there. And you will be part of a system of continuous care. It will be, in effect, a civilian VA.
And we probably should open this up to some Q&A, but I just sort of want to sum up. And I think what I'm what is happening, what you're saying is that though the healthcare reform did not mandate anything like the creation of integrated healthcare of the kind that could bring costs down in this country and increase quality, there's the makings of that if there's some initiative shown by the nation's governors, mayors, nonprofit sector to begin to create these networks that can take those who are going to be getting insurance through the government, if we can find ways of incentivizing these folks to go to these networks, these St. Elsewhere networks, and see, and you might see the creation in the not too distant future of something like this. Well, I hope you're right, and for this reason, I think this is the handful of things we've published in the last 10 years. This is an idea that I think does have the capacity to transform the country. I'm sure there's some skepticism out there, so I'd like to open it to the floor. Our guy Daniel Mandel has the mic. Please, when you get it, state your name and your affiliation if you have one.
Yeah, I'm Steve Tellis at Johns Hopkins and the New America Foundation. The question I was thinking about when you guys were talking is the real problem here is a diffusion problem, right? How do you actually create a mechanism that causes this to spread, right? And so one theory, the theory of the stimulus, is you give people an economic incentive, right? You give them some money and try and buy them off. But that, and that's sort of the mechanism diffusion we have most available to us when most of us think, oh yeah, that's how you get people to do things. You give them an incentive because the economic kind of model is so prevalent for us. But of course, there's other mechanisms that cause diffusion too, right? I mean, one are professional norms, right? Things become sort of locked into an important profession, and the profession causes things to diffuse across lots of different organizations, right? The people who are those professionals inside the organizations then lobby for the organization to change, right? And then at some point you also get what sociologists call mimetic mechanisms, right? That is people simply mimicking whoever is seen as being the leader in their field, right? That is, so if some really prestigious organization does it, then everyone's saying, oh, they're doing it, so we should do the same thing. You see that often from sort of elite universities, and then patterns, trickle down. The other mechanism, of course, is you get entrepreneurship, right? You get somebody who's out there actively trying to evangelize for the idea. Now, the problem is the only one who's actually got an economic incentive to evangelize for this, especially at least for the health IT, are people who are doing exactly the wrong thing, right? They're not evangelizing for the cheap thing. So I guess one thing I'd like you to talk about is what are those mechanisms for diffusion that you can see, and which ones seem to me most plausible, given that the pure economic incentive model of diffusing this doesn't seem to have really worked, and probably it's a good thing it didn't work.
Well, it's usually a tough question for you. Well, let's be frank. This healthcare legislation does not directly take on the skewed incentives in our healthcare delivery system. We're still living in basically a fee-for-service world that pays providers for performing procedures and pays no attention to whether those procedures result in well-being. And until that changes, we're not going to see gigantic, rapid diffusion of this model. But here's my hope. The VA itself was incredibly unpopular among vets coming into the 90s. And most vets, the only ones that used it were ones who were just too poor to have any alternative. Today, if you talk to veteran service organizations, their biggest gripe is that more vets can't get into the system because of various eligibility restrictions. So word has gotten out among veterans that this is a great deal, and why the hell can't I get in? I serve my country. Why can't I get in? Now, what I'm envisioning, if we could replicate that, even with demonstration projects, it might be that the original political support for a local civilian VA was included some fiscal conservatives, some people that had some hard feelings about the Medicaid population, said, you know what, we're now paying for your health insurance. That doesn't mean you get to go to just any old hospital you want. We're going to give you some tough love, right? So we're going to create this second-tier healthcare system, right? Where you're not.
Which, by the way, is what George Bush did. The one thing George Bush did for healthcare was increase spending on
the clinics.
On clinics. Yeah. There's now hundreds more of these. What are they called?
Community health.
Yeah, right.
Right.
And I gather they have mixed results, but there are a lot of them now.
Right. But suppose it's not just a clinic, but it's a fully integrated system, and over time, it begins to gain the reputation that VA has among people that are anywhere close to the military, which is, this is good. Why can't I get in? Right? Now all of a sudden, the whole dimension of it is changed.
So you can imagine like Oklahoma or Arizona, right? The Republican, flinty, kind of irritable political culture saying, all right, we didn't want health care. We didn't want to subsidize all these people with health care, but we got to do it, but we're going to do it by forcing them to go into these clinics and these
civilian VA. And pretty soon, word gets out that, hey, I had a great experience there. And did you know what? My complete medical records were there. And then somebody on the other side of town that's at the prestigious academic hospitals, it's like, well, wait a minute. How come I don't have electronic medical records?
Or if I got a company, right, and I'm struggling to provide health care, and I hear that there's a network out there that I could provide better health care for my people for, I'm going to lobby to get in, I would think.
Yeah.
So does that partially answer your question?
Yeah, partially. To be continued.
My name's Cooper. I run a nonprofit that looks to be a supplier from a nonprofit perspective of supplies, equipment, and solutions to a sort of network of 7,500 community health centers, and in the law there's a provision for 11,000 more. The idea, I also sit on the board of a community health center network of 30 clinics. And the last thing the management of that particular health center and those around the country are focused on is collaborating, pursuing a model such as you suggest. They're all buying individual proprietary EMR programs and diligently finding ways to marginalize the consumers who by law are supposed to control these community health centers. Now, the proposition that I think is a real possibility for creating a public option in the private sector is collaborating these health centers, throwing in public hospitals, throwing in teaching hospitals or medical schools. From a nonprofit point of view, you could be at 100 million patients in not too long a time, and they would have a business model because health center patients are 20, 30, 40-year relationships. If the relationship is where you produce the business case, the capital markets, Wall Street could do something constructive. But my point is, if the business case is the long-term relationship and you have this network that's just there, just ready to be organized. The shortfall is the people who have an interest, who are paying the bills for this health care. There should be some collective that, just from a point of view of saving money, is pushing an obvious option like institutions that are just here for getting where we want to go.
Great question. What action other than standing back and waiting for entrepreneurial people to grasp the brilliance of this idea? What options are there at the federal level or whatever to do what the gentleman says and organize, get this going?
Well, if you're a governor and you're looking at newly mandated Medicaid coverage, you're looking at Medicaid bill that's going up and up already. Now you've got all kinds of new induced demand on your system. You might be that entity that says, you know what, we can create a real competitive advantage for our state and solve some of our fiscal headaches if we take a more hands-on approach on the actual provision of health care as opposed to just administering its finance. California came very close 2 years ago to having a comprehensive universal health care system of its own. And business was at the table because they understood that it was important to their bottom lines and to the economy of California as a whole that they get those costs under control. And yet the thing that broke the deal at the end was the business community. This is like the business roundtable types, the big business. They said, well, you know what, we'd be willing to pay even a 5% payroll tax to get this thing under control, but what assurance do we have that it won't be a 10% payroll tax 5 years from now? And the various reformers that include Len Nichols here at New America and Arnold Schwarzenegger was pushing for this, they didn't have an answer for that. They just, I don't know, But it seems to me that if we do have an answer to that potentially, we're going to have this hands-on control, and we're going to have this integration, and all the clinics and public health care systems in California are going to be looped into one virtual organization, that we're going to take child protective services and our various mental health efforts, even some financial education. All of this can be part of a totally integrated system that can serve a population and do it in a thrifty way. Then that becomes quite a sales case, and it might not be an entrepreneur per se that does this, but a government that's on the hook for these costs, can, from its own point of view, enhance its resources by doing this right. And so this is something I think could be done at a state level. It could be done at a county level, city level, right? And it all comes down to whether there's enough grassroots initiative and wisdom. It kind of reminds me of that moment that, when Ben Franklin came out of the Constitutional Hall after all those deliberations, and people were asking, what did you do in there? What did you create? And he said, we created a republic if you can keep it. And I think that's kind of the moment we're at here. We've got the basic framework there, right? But it's going to take lots of individual and civic society initiative to get it done. The irony of this, is that far from this bill being a government takeover of health care, it's about as far from the opposite it could be. It's mostly a bill that mandates that we all go out and buy private health insurance, and basically says nothing about the provision of health care, right? But does give us some tools as individuals and policy entrepreneurs to turn this right.
Hi, I'm David Bank with Civic Ventures, although this has nothing really to do with that. But I'm wondering what you think of the proposition that maybe the question on electronic medical records is not really the system or the technology, but actually the sort of control of the data. And the argument, and it's not my argument, but is that that most of medical records actually are already electronic. That if you take the labs, the images, the insurance billing, that's all. Anything that requires you to get somebody paid tends to be electronic.
Right. That in the 60s.
The only thing that's less electronic, although maybe it's starting, is the actual charts. But the argument is that 90-some% of whatever you want to diagnose is knowable from the meds and the billing codes on the insurance. And so if there were some mandates about that data being both interoperable and accessible and sort of under the control of the patient, and through cloud computing and everything else, that's not all, that's not impossible anymore. That you could go to between different systems, as the Kaiser VA thing is, or between a community clinic and a public hospital. Everybody's accessing multiple systems, so that it's really about empowering the consumers to have their own data that they can then be portable with wherever they go.
Well, I think that's a huge part of it. Having an electronic medical record that you control and that you have access and that you update, this is a matter of behavioral psychology, can be a wonderful spur to controlling your own blood pressure, for example, right? Or minding your glucose levels better. So I think that's good. But another part of this, and this is the part that really comes from the VA experience for me. For me, it took me literally several years to figure out why it is that what is this big deal about health IT, right? I can understand that there's some efficiency in not having to keep always paper files and file clerks and stuff like that. But beyond that, what's the big thing? And I think the very subjective truth of this only came through to me when I was at one of these conferences with these hard hat dudes, who, by the way, most of them they're in the VA because they were draft dodgers during the 60s. They now got kind of graying ponytails. I was asked for prescriptions for medical marijuana twice at this conference, and it was in Seattle, and so I had to say, dude, So there's some pretty funky guys who actually created this code. But one of them said to me, and I think it's really true, he said, Vista, that is the name of the program, which is really 18,000 different programs written to start with on Tandy computers. Vista is not a program. Vista is a process. And what he meant by that was that it is like other open source software at its best, created with intimate collaboration between the actual coder and the user. So a common scene in the VA circa 1990 would be you have some pharmacist in Minneapolis who has an idea for electronic dispensing. He's got an idea. He went to Avis at the airport to return a car. This is an actual true story. Only it's a she. She went to return a car, and for the first time she saw this guy come out and wave this wand and hand her contract. And it's like, how did he do that? Come to find out, there's this barcode stuff. And you remember George Bush the First? He was innocent of this thing too. And so she literally went back to her hospital in Topeka and went down to the geeks in the basement and said, you know what? I just saw this amazing thing at the airport. And this light bulb went off in my head that if they can do that with rental cars, why couldn't we do that with meds, right? And so she, a nurse, and these geeks just kind of worked on their free time until they got that thing going. And, of course, by the time they got it going, they had total buy-in. And eventually Ken Kaiser heard of it in Washington, and it became universal practice in the VA and is now beginning to migrate out elsewhere. That's an example of how this is not so much a particular code or particular language, it's a process. And that's, I think, at least as essential to the diffusion of health IT into the actual practice of medicine as individuals controlling their own healthcare records. I think they're both important, but if we don't get that piece of it, then doctors just don't buy in. it wasn't invented here.
Yeah, we'll try that. That's a good idea, Daniel. We'll have we'll have 3 people ask questions. Please keep them brief, and we'll try to get them all in at the end here.
I'm Jean Salmon from Network on National Catholic Social Justice Lobby, and I wonder if you can tell me if there's anything in the new law that has any kind of clearinghouse to see what demonstration projects are good and maybe replicate them somewhere else?
Okay, great. Any other?
Yeah, on page 24 of your book, you mentioned that the one thing that Vista does not do well, and I happen to know this from my own experience because we're an employer-sponsored health plan, and that is billing. And based on what I see from the VA, that could be its undoing. Could you comment on that?
I'm Elliot Wicks. My question concerns IT also. I know that Kaiser, when they were putting in electronic medical records, spent a huge amount of money and then had to abandon it. And I wonder what they replaced it with and why they didn't know what the VA was doing. And the other thing, I just wondered, what about the healthcare system in England? I know they were spending huge amounts of money and paying IBM and others to develop it, and I wondered what happened there.
One thing to keep your eye on the clearinghouse thing, there's a lot of money going into what they're calling a Center for Comparative Outcomes Research, which will presumably give us a lot of data on what particular procedures make sense. Does back surgery actually work? Are stents a good idea? That kind of thing. There's not anything sort of equivalent in scale that I'm aware of that would look at these various demonstration projects in a systematic way. But it is the intent of having these demonstration projects that we would research them and study them and see to what extent they were replicable. On the billing question, yes, that has been a problem with Vista for people who do billing, but not anymore. MedSphere, which is a private company that installs Vista, has a new billing module that it will apply. That's how Midlands Memorial does its billing. And of course, the VA itself collects a lot of co-payments, and so it's not a total obstacle. Also, remember, this is not a program; it's a process. You want a billing module, whatever little tweaks and twists. It's all open source. Just go look at it, tinker with it, fix it, make it work for you. Kaiser did have a very painful experience with its proprietary system. I think it by now has, like Sutter and many other the big guys that had these just horrendous experiences with proprietary software, they persevered and they got something that's up and running and it's good, and it just was much harder than it had to be. Why didn't Kaiser just go with Vista? Well, if we're talking early 2000s into the mid part of that decade, if you were somebody contemplating this question, you would be visited by a proprietary software salesman who would tell you, yeah, that Vista thing, that was ahead of its time. That VA really wanted. But did you know that the VA itself is walking away from Vista? That's an old legacy system that the VA itself is not even has no plans to stay with. And the kernel of truth behind that was that in the Bush years, particularly towards the end, they more and more were outsourcing health IT to their friends in the proprietary healthcare system. So among the most notorious examples was the lab module in Vista that everybody agreed needed updating. It was written in the 1970s. It was time to do something. But rather than go with the usual process of having hard hats in collaboration with VA doctors and nurses do it, they lent out a big contract to Cerner, which has the largest Washington office of any health IT company. So they now have, right smack in the middle of Vista, this black box, which is the Cerner lab module. Nobody knows what's in it. They just kind of have to program around it. It's like a cancer cell in the middle of this open source thing. So that's part of the subjective cultural reason. Another thing, if you ever have a chance to talk to a Linux salesman, these are guys that basically will install the equivalent of Microsoft Windows, open source software that's free. Turns out that's a hell of a sale, right? You go into some Fortune 500 company. Well, put yourself in the position. You're the vice president, and your CEO has just told you, we got to update all our computers. You go out and figure out what the best system is for us to buy. And so you talk to a bunch of people, and you educate yourself, and you find out there's this thing called Linux, and it's free. You know, and all you got to pay is some minor consultant fees and install this, right? And you go back to your CEO, and the first thing is he's never heard of Linux, and then it's free. Like, well, what's wrong with it, right? And I talked to the actual hard hat that evolved into a Linux salesman, and he told me that the only way he could make these sales was to build in all this expense. You know, it's like, no, it's not free. It's like $20,000. You know, and you know, just in the way that Cadillac sales might fall if they cut their price, I think that weird kind of supply-demand curve works here. Nobody wants to be the guy. It's the same thing as like you're the purchasing or the guy works in the mail room, and you know, you learn that DHL will deliver this for half the price of FedEx. Do you actually want to make that decision? Because when the thing doesn't show up, people say, "Why didn't you use FedEx?" Like, I don't know. I thought I would save some money. You know, so that's the world as we find it.
Folks, thank you very much for coming. Appreciate it. Round of applause for Phil Longman. Thank you.